Hi, everyone. I'm Maria Theodoulou. I am a medical oncologist who is the program director of breast cancer up at New York Oncology Hematology in the Capital District. I've been here now for just a little over 8 years after spending 35 years at Memorial Sloan Kettering Cancer Center in New York City. I am pleased to present another chapter in our podcast series educating, informing, questioning, understanding all the different aspects, not only of breast cancer survivors, but those women and men who are interested in good health and curious about where we're going today. We're going to be covering it all. And today I am so pleased to be with Sandra Sanderson, who I know is Sandie Sanderson from hundreds and hundreds of patients, who is an incredible physical therapist, lymphedema expert, and probably has lots of other things going on under her umbrella. And I'll let her talk to you about it. We're going to talk about one of the issues that concerns so many of my patients, whether they're female or male, and that's the whole issue of lymphedema. Who's at risk? How are we dealing with it? What's happened in the past 40 years regarding its management when I first got into the breast cancer environment? And hope you'll all find something that will be helpful from this podcast. Sandra, would you tell us a little bit about your background, who you are, how long you've been here?
Hi, I'm Sandie. I like to go by Sandie. I've been a lymphedema therapist 20 plus years and physical therapist a lot longer. I was very interested in becoming a lymphedema therapist when I was in the rehab setting and there was a lot of swelling and wounds, and we did all that way back in the day. Then I was pulled in by our oncology team to be on their committees and things. So I also have extra training in breast rehab. So not all lymphedema therapists have a lot of training in breast, but I really have focused the last all of many, many years on just breast rehab. So that is my specialty, and that's really what I love.
So, could we just define for everybody who's looking in on this program what is lymphedema?
So, so if you broke the word down, lymph, edema meaning swelling, lymph meaning your lymphatic system. So our lymphatic system is responsible for filtering everything in the body that the veins don't transport. It is a one-way transport starting at the fingers and the toes, and it heads towards a lymph node for filtration. Has to go through many lymph nodes before it reaches its final destination. So if we're talking about the hands, we're fingers traveling all the way down through the axilla and ending in the terminus or the cervical triangle. So there is quite a long pathway. And if we have a surgeon remove lymph nodes to see if a cancer has spread into the axilla, the disruption of the lymphatics can occur. So the more
I always
lymph
tell my
nodes,
patients to think of two parallel parkway systems, whether you're on the Grand Central or the Long Island Expressway. I guess up here, I 90 or 87. If one of them shuts down, traffic will feed into that parallel pathway and we can wind up with gridlock. So I give it back to you.
we can, absolutely. Now, it doesn't mean that since lymph nodes were removed, that we're not going to have any lymph flow. We absolutely are, because the minute those lymph nodes are removed, lymphatic regeneration occurs. So they want to find another lymph node. That's the job of the lymphangion or the vessel. So it looks for another node. So
Yeah.
there is some
Yeah.
regeneration going on.
It's interesting. Patients will say to me, "Oh, Dr. X removed 7 lymph nodes. Now what's going to happen? I don't have any more." And then I'll tell them, I've had patients who have come back with a path report of 52 lymph nodes removed.
Correct.
Not every single lymph node is removed. It's usually what the surgeon identifies either through lymphoscintigraphy and mapping or by feel when they're in there, feeling the fat pad. But everybody has a different number of lymph nodes. And what Sandie beautifully said was this regeneration. So we're not left hanging without any pathways.
Correct. Also, we also say, well, how come you had 3 lymph nodes removed, and the person sitting next to me had 11 lymph nodes. The person with 2 or 3 lymph nodes has swelling in the arm, and the other person does not. There's a lot of factors that go into that. Fortunately, the surgeons are rethinking, right? We used to just go in and take any lymph nodes. There was really no thought about it. And like even my mom, for instance, 19 lymph nodes way back in the day, they wouldn't do that now. All of them were negative. So, but there are other factors that happen, that the person with 2 lymph nodes has lymphedema, and the person with 11 lymph nodes does not have lymphedema. And a couple of those things could be, the way you're made, right? Sometimes we have a beautiful connection between the wrist and all the way to the axilla. And sometimes there's a little break in the action. And they can identify those things by simply injecting indocyanine green at the wrist and watching the flow. And if they can see a backflow or dermal backflow, or they see a break in the action, that can help a doc identify a need for reconstruction, or even why you have lymphedema and why somebody else doesn't. There are other
Let's
factors.
just talk
Yeah,
briefly
go ahead.
about why lymph nodes are even evaluated. We know that with invasive breast cancer, regardless of the subtype, there's always a concern that cells may have jumped into the lymphatic system because it does drain all the byproducts from the breast to those first plumbing segues. And it's important to identify if cells have left the originating breast area where that tumor was born, and whether any cells have landed in any of the lymph nodes. The reason why that's so important is, number one, it gives us an idea about the risk of a patient having a recurrence somewhere outside of the breast and the lymph nodes. It allows the surgeon to really perform the most optimal local control surgery. Sometimes they may have to go back to take a few more lymph nodes out. It allows the medical oncologist, the me person, to be able to design an appropriate treatment that will be a systemic treatment, head to toe, that will decrease the risk of any recurrence distally, locally, outside of the breast. And because that's such an important issue, we are now getting to a place in 2025 where we're discussing de escalation. Who may not need a lymph node dissection? Perhaps a specific kind of breast cancer has very little risk of traveling outside of the breast. When I see 60 patients in 1 week, I am seeing about 15 different types of breast cancer, all behaving differently, all with different red flags. And to what you said, Sandie, all in different gardens that will perform very differently than the person next door. So, lymphedema is unfortunately a side effect of a lot of these interrogations and investigations when we're trying to stage a patient early on. But because of Sandie, because of the evolution of lymphedema therapy, and even more importantly, in my estimation, breast rehabilitation, patients who have breast edema, who may have swelling from their radiation. And now, and I hope we'll be able to talk a little bit about lymphovenous bypass as a new modality that is changing the face of everything. Why don't we start from the very beginning? A patient undergoes even a sentinel lymph node, which is as minimal amount of lymph nodes that we can identify for that patient. And now they come to see me. They've had their radiation, and the patient tells me, Dr. T, I'm really tight in this arm on the side of where I had my surgery, and it's beginning to feel a little swollen. Sandie, what should I be doing? What should the me person be doing at that point in time?
You mean the patient? What should the patient do?
The provider who's seeing the patient with that complaint, what should Dr. T be thinking and doing?
Refer to a lymphedema therapist immediately. The
Yeah,
sooner the intervention, the better the outcome.
that's what I
And that,
wanted to hear. And The
Yeah.
providers, whether they're MDs, DOs, NPs, PAs, the first thing that you should be doing really in that clinical setting is measuring the arms,
Yes.
making sure that there's no evidence of infection in that extremity. I check the cuticles to see if somebody's been pulling, if there's any swelling around that cuticle, and immediately referring them to
Yes.
lymphedema therapy. And then the patient comes to see you, Sandie. What do you do for this patient?
I'm immediately educating, of course, with lymph node removal, no blood pressure in the arm. I'm still sticking by that. I know some surgeons are kind of saying, no, it's not really that important, but it is. I do still get patients that come to me that have had a blood pressure in the side of the arm that has had lymph nodes removed and they have swelling. They also are educated for needle sticks in that arm, any high risk activities, heavy lifting, rowing, pushing, pulling. If someone's reporting that they have pulling in the arm, they could have axillary cording. That is could impair the way they raise their arms overhead for mapping during radiation. So a lot of times I'm squeezing folks in immediately because they cannot lift their arms to get into that position. So again, earlier intervention is a must. And then I educate, I am going to tell them no blood pressure, no needle sticks. I'm going to give them exercises for stretching. I'm going to give the girth measurements, and we're going to, depends too, folks come to me with breast lymphedema. So I'm going to teach them how to manage that, do a breast massage. I have things that I sew, chips bags. I have Mobiderm that I place in the breast that helps decongest the breast. So that is also different than arm lymphedema, but it is a huge thing that I work on now since they don't take so many axillary nodes. We have a lot more breast lymphedema.
So I will say that the no blood pressure, the no needle sticks were a standard of care for probably the first 2.5 decades of my being in practice. About 15 years ago, papers were published saying that it may not make a difference. But, I look at the risk factors of the patients. If somebody's had an axillary lymph node dissection, not just a sentinel, and radiation therapy, and usually if you need an axillary lymph node dissection, you're getting radiation therapy. Uh,
Right.
those patients are going to be at a much higher risk of developing lymphedema with any trauma to the
Yes.
arm. Someone who's only had one sentinel lymph node removed, I am more relaxing in my recommendations, but I am very, very strict about hygiene, manicures, making sure that they know the salon they're going to. Maybe they can bring their own instruments that are sterilized, um, and never losing the possibility that there may be a clot, something called a deep venous thrombosis that can develop in an arm when there's stagnant blood flow. So the physician should always think of that and rule that out with an ultrasound before we have active physical therapy in a patient. We're seeing, I would like to hope and believe that we're seeing less lymphedema than I did 20 years ago and 30 years ago, but it's still there. And I will say, and Sandie, you see an awful lot of my patients. It is remarkable after they've gone through a therapeutic regimen or protocol with you, how they will come back to me and I see complete normalcy in the arm. The question that I have for you, that is a question that's posed by many patients, is if I've had lymphedema once and Sandie Sanderson has made it go away, am I at risk for developing lymphedema again?
Yes, you are.
Mm-hmm.
And even if it's 15, 20 years down the road, because folks will come to me and they will say, oh, I used to wear that sleeve. I used to do those exercises. And then fast forward 15, 20 years, they're coming to me with a swollen arm. What did you do? Maybe I took a flight. I didn't wear my sleeve. Maybe I lugged my luggage and put it in the overhead bin. So, and then they say, but I've been great for 15, 20 years. You are always at risk for developing lymphedema. And of course, the older we get, some of our vessels don't work as good. So, things do slow down. And so, and I do see that. I do see
Mhm.
that.
I tell patients that if you've developed a precancerous lesion in your breast and surgery was required, something that's in situ, or a breast cancer, if your breast has done it once, if you have done it to yourself once, you are at risk for doing it again. And that's why we continue to follow patients closely after they've been diagnosed with their first breast cancer with imaging and physical exams and surveillance. So I think once you've gone down that tricky road once, you're absolutely right, Sandie. We always have to be aware that we're a little bit more vulnerable. And I have seen lymphedema occur 10 years, 15 years later, certainly in lesser
Yes.
percentages. I don't want our audience to think that they have to start measuring daily. It's
Right.
less likely and unlikely as we move forward with years that pass. But we need to be aware of risk factors. And certainly, if someone develops lymphedema, even if they're not seeing their oncologic providers or therapists after a decade or 15 years, they should be in tune with, gee, what's going on that there's trapping? Could there be a new lymph node in the brachial plexus? Could there be a clot, as I said before? Or could it be that I picked up my two grandchildren at the same time with one arm lovingly? So, important to not use breast cancer, its diagnosis, its subsequent complications, lymphedema, whatever, as an umbrella casting a shadow over
Right.
oneself, but use it as an umbrella by your side to always keep you steady and a reminder that you are the most proactive person for your good physical well care. Sandie, can you speak a little bit more to what kind of risk factors may increase lymphedema risk? Does obesity increase lymphedema risk? Does diabetes increase lymphedema? What do we know?
We do know that a higher BMI, you will be more at risk for lymphedema. Typically, with our slender gals, we often see more axillary cording. It just seems to be more present, and our larger gals more lymphedema. I mean, it just kind of makes sense, right? There's a lot more tissue to have to kind
Right.
of go through.
If you were to
Yeah,
hypothesize, those little gals, those skinny girls, when one goes in to make that cut, all the tendons, everything are right there. So easy to nip something.
right. Also, other risk factors are your actual, well, I talked earlier about how you were made, right? Your
Mhm.
connection between the flow, right? Do you have a complete connection or don't you? There are, even if you had a complete, let's say you had a mastectomy or you had tissue sparing because you were going to have an implant, those lymphatic channels have been spared or saved. So you don't tend to have truncal lymphedema as much as someone that is not going to have reconstruction, but they're having, a mastectomy and all those lymphatic channels, like they kind of basically take it right down. So that's a different risk factor. We also know that um, if you have activity in your lymph node, there was a study done by Newman, and it was about if you're already got lymph nodes that are active and the surgeon goes in and takes those out, those sprouts have already occurred in the lymphatics because that's where cancer wants to go. Well, cancer is gone now, but the sprouts are still there. So the lymphatic regeneration is there, and actually it spares you from having a lymphedema because you've already had all those extra connections. So that's almost a good thing in a way. Hard to say that, yeah, I have axillary involvement, but removal of those nodes and the cancer is gone, but the sprouts kind of save you from having any swelling.
Right. Those
We
those cancer cells have created a trabecular pathway, and now you pull out that diseased node, and you've got maybe a more robust lymphatic pathway than you had before you had the breast cancer. Um,
Right.
I am fascinated, and certainly all of these studies were initiated at large tertiary institutions. They were doing them before I left Memorial Sloan Kettering with lymphatic bypass and lymphovenous bypass, which has really been a game changer for a lot of our patients, even those that have developed a grade 3 lymphedema. Can you speak a little bit about that to the audience?
I have had a few patients with complete axillary reconstruction. Sometimes the vascular system is such they can't have it, but folks have come from Memorial Sloan Kettering with reconstruction. They're doing very well. It's typically advised to wear a compression sleeve, just almost as a precaution. And but they're doing very well. It
So if one
is
can, yeah, if one can think about it, if whoever's viewing this can think about it, I talked about two parkways parallel to one another. If your lymphatic system is scarred or somehow damaged, it's not flowing as well because of whatever intervention, what the surgeon can do now with microscopic surgery is clip off the diseased portion of that lymphatic vessel and bring it up and sew it to a venule, a venous,
yeah,
and make a nice flow. So if exit 4 on I-90 is vulnerable to an earthquake and it no longer exists, we can still have people drive to exit. I guess 3 would be the next one. You can tell I'm a New York City girl, and turn around on different routes to get back to where you have to go. Um,
yes.
and yes, you see those patients, Sandie. And are there other restrictions that you recommend to these patients that have gone through this bypass surgery?
Um, Well, we really, once the surgery is over and we're, of course, measuring for lymphedema and they're doing wonderfully, we want to introduce exercises
Mhm.
because the exercises will strengthen the muscle, therefore strengthening the vessels that go through the muscle, which would be vein, artery, nerve, and your lymphatics. So you do need to have an exercise program, not only for good health, but a lot of these folks are on the aromatase inhibitors, which, can steal from our bones and our bone density can be challenged. So those exercises are super important. So everybody that comes to me will get an exercise program geared toward them. So I would say stay as active. You don't have to swing around heavy weights to make this effective, but whatever you like as an exercise, yoga.
Patients say to me, "Oh, now that I've had my surgery, will I be able to golf again? I was on a tournament." And I always say to them, if you golf before, you can golf again. If you never golf before, let's be careful of when we're going to start golfing for the first time. I Massage therapy. It sounds so luxurious, but when it comes to lymphedema, talk to us about massage therapy.
Massage therapists, and they hopefully are educated that they are not going to do anything deep tissue to a patient that has had axillary node dissection. I make sure that I let my folks know that if they are going to have a massage, that I basically stay away from the quadrant where the surgery was performed. um, it is the lymphatic vessels are superficial, so when I'm doing manual lymphatic drainage, it's a very light skin stretch. I can manipulate and I can decongest an area, but a massage therapist really digs in to get the muscles and to release those trigger points. So that would actually crush some of the lymph vessels. So we have
Mhm.
to be cautious and educate our patients to, when they are going to a massage therapist, please do not have them do a deep tissue massage on that quadrant.
I'm so glad you reviewed that. I have patients who say, "Oh, we're going to go to Aruba to celebrate the completion of XYZ, and I'm going to get a massage every single day, deep tissue, Swedish, hot stone." And I'm like, "Whoa, wait a minute, wait
Yeah.
a minute. Let's talk about what's safe, what can get us into trouble, what's going to feel good, and maybe later on what's not going to feel good." So you covered exercise, so important. You covered um, what we should and should not know about massage therapy. Certainly, diet and weight management so important. Preventing infection, which I alluded to earlier, whether it's just a manicure or a bug bite, paying attention to whether you're going to have a significant infection. The lymphatic drainage is there to bring all the bacteria fighting cells to the area that's been injured. That's what causes the swelling. But then when things settle down, that liquid, that fluid has to leave. And we
Yes.
might be overflowing the parkway, so to speak. We don't want gridlock. So
Right.
pay attention to all of that. Um, I think it's so important to have a holistic well care program, which we are now beginning to talk about to pilot. We've seen results come back from incredible laboratories as well as clinical trials looking at patients by way of their obesity, nutrition, BMIs, exercise, whether they're stage 1 or stage 4, that the healthier we keep, the more plan forward our diets, the
Yes.
exercise that we can manage actually will impact on how well we're going to do and what our overall disease-free survival or disease behavior will be. Now, Sandie, how do we clone you? Because there's not enough of you. We certainly need more and more Sandies everywhere. How easy is it for a patient to get referred to you? What are the insurance requirements? Patients will say, well, thank you, but I don't know that I want to, have any more bills. And there's a lot of bias and misconception. Let's clear some of that up for some of our patients, especially our elder patients.
Folks can come. We take every insurance. We're hospital based. They're typically a copay, just as you would if you were to go see any doctor. Also, the um, yeah, and most insurances cover the therapy when oftentimes providers say, I'm going to send you to physical therapy, and they just think that we're going to make them do exercises. Well, this is a very unique and targeted therapy. There's a lot of lymphatic work, there's a lot of education and exercise and a lot of manual work. And plus, I have a few more things, up my sleeve to help folks. And usually, when they come to me, they'll say, I really was hesitant about coming. I didn't know what I was going to find, but I'm so glad that I came because I learned way more than I ever thought I would. So I think educating folks and sometimes even some great support groups around are telling people the great things that can come from lymphedema therapy. So, we take everybody. We don't turn anybody away. So I would just come once and see what it's about.
What about extreme temperatures? Things like saunas, heating pads. What do you say to patients who want to have extreme temperatures because perhaps there's some psychological therapeutic benefit to them? Is there concern when we're dealing with that affected surgically, um,
Yes,
perhaps
yes. And
lymphodematous arm?
yes, that's on one of my sheets for my reducing the risk for lymphedema. And it's part of the education component. And people kind of get a little sad, but I say to them, okay, so they remove lymph nodes. So you do have an slightly impaired lymphatic system. And now you're going to dunk yourself in a heated environment, speeding up what your vessels are doing. And now, you're at risk for actually creating a swelling. So
Mhm.
sometimes it's a temporary swelling and sometimes it's not. So I always caution, we really don't recommend saunas and hot tubs for folks with axillary dissections.
Good.
Some people do it anyway, and they're going to. And I just say, okay, I've just informed you why you shouldn't, but that's your choice. Yeah,
Okay. I'm
yeah,
glad they're hearing it from you, Sandy. I really am. Um,
yeah.
what about patients who come to you? They sometimes have a protocol of 8 regimens, 8 treatments, 8 cycles, whatever we're going to call them. And are they then eligible if they notice something different, new, concerning to come back to you? Or are they only allotted a one time protocol?
No, everyone, I have a very high repeat. And I think what happens is we're good for 3 months, maybe. I only see folks once a week for 1 hour sessions because that's really all my schedule allows. And, those folks have a lot of appointments as well. So we try to make the most of each appointment, give a lot of homework, and, they're, they might, I don't know, 8 times, 10 times. And then I say, let's just take a break. You've got all the tools that you need. Everything's looking fabulous. You've got your exercise program. And then Christmas hits or something like that. And then they've done the totes from the basement, the Christmas tree, 9 trays of cookies, and this happens. And then they come back and they're like, oh my gosh. And that I consider a high risk activity. That's a lot of things that they're doing, a lot of lifting, a lot of busyness. And that can create a lymphatic exacerbation. We can get right back to it and we can resolve that in a few sessions. I call it a tune up. And folks are always thrilled. And I do see a lot of folks. And sometimes it's just to ease their fears. We're here to help you, and I'm always going to be here to help you. And not to say that you came and you're done, because I do see a lot of folks return.
It's interesting to me that oftentimes there's this feeling deep inside in that patient who's just gone through their surgery, have just gone through their chemotherapy, have just gone through their radiation therapy. They just want to get back to life. And as soon as they start feeling that little bit of precancer energy, I see a lot of comebacks with after doing repetitive whatever, repetitive lifting, repetitive cleaning, repetitive, where that arm was not used to all this repetitive. And it's really moving slowly, moving carefully, like you would anyone, any child.
Yeah.
Moderation, and certainly uh, pull the bell, blow the horn, make the call, and speak to your provider if there are any signs of infection, if there's any redness, any pain in the extremity, any heat, swelling, fever, or in the breast.
Right.
Patients sometimes will come to me and say, oh, my breast, I please give me another prescription to go back to my physical therapist. It just hasn't felt that good the past couple of weeks. And I undo the robe and there's a full-blown cellulitis. We don't want that. So always better to call, have yourself evaluated, see Sandie, see me, or whoever it is that's caring for you. Better to waste our 5 minutes
Yeah.
and protect your weeks and months. At least that's what I say.
Yes. Yes.
I hope all of you who are listening to this program will turn it off and say, gee, I just learned something new. And if it's only one something new, then Sandie and I have done what we've set out to do. This program is really secondary to a grant from one of my patients from Memorial Sloan Kettering, who has given me annual grants for patient education. And now that my grandchildren have taught me about YouTube and podcasts, we are designing a whole host of programs to bring to all of you. Sandie, I can't thank you enough for spending this time with me. I can't thank you enough for how patient you are and how careful you are and how enthusiastically educating you are with the people that come to you for therapy. Um, Thank you. That's all I can say. Thank you.
I appreciate you letting me have the time to educate and just have a chat with you. And hopefully, folks will feel more comfortable and understand why it's so important to come to a therapist early on, even if it's just one time. Thank
And
you.
as new information comes into this arena, you'll be seeing more programs with Sandie and myself. Bye, everyone. Thank
Bye
you,
bye.
Sandie.
Thank you.
Bye.